So I am delighted today to have Nina Kottler as our guest at this AIMI-IBIIS seminar. Nina is a longtime friend of the AIMI Center and many IBIIS researchers, and has participated in many of our activities in the past. And we're so happy she can be here today to talk about her work bringing AI to clinical use. So Nina got her bachelor's degree in math, excuse me, from Emory University, and then did graduate studies in applied math at USC, and ultimately got a master's in applied math from NC State. Then went back to do her pre-med requirements at Wellesley while working as a system analyst at Raytheon on the Patriot missile system. Very interesting. Then an MD at the University of Massachusetts, residency at UCSD, and then joined one of the first teleradiology practices, Nighthawk Teleradiology, based in Sydney, Australia, and served as a medical director there. She devised a compensation model for the merger of two Nighthawk radiology services, and now serves as Associate Chief Medical Officer for AI for RAD Partners, which is the largest radiology practice in the United States, with over 2,500 radiologists in 35 states, reading 49 million cases a year. She's been awarded the RAD equals Trailblazer Award and an RSNA Research and Education Foundation Röntgen Resident Research Award. She is one of the most influential AI leaders in radiology today and has as much or more practical experience implementing AI at scale than just about anyone. So many lessons today, I think, certainly for radiology, but also for other specialties, pathology, cardiology, ophthalmology, and many others. Title of her talk today is AI in Clinical Use, Lessons Learned. So please take it away.
Thanks, Curt. Let me share my screen. Hopefully you guys can see that.
Yep.
Yes, Ella is nodding your head. Thank you. Great to see you, Ella. All right. Well, I have been able to, luckily, in my position, get a lot of experience using artificial intelligence. And I really just wanted to take some time to share some of those lessons learned with you all. I strongly believe that AI is foundational within radiology. Yes, we're just still early on, but it's going to become an integral part of everything we do. So today I'll tell you about some of the lessons that we've learned along the way. Here are my disclosures. They're all related to being, a partner and an equity owner at Radiology Partners. Some things that I do for them as just a friendly physician. And they do have minority interests, but we're not selling anything today. We're just talking about education, how we can all improve ourselves and learn more about artificial intelligence. Okay, I think it's important whenever we're talking about the future to look back at the past. And the past in radiology, well, for me, this is what radiology looked like when I was a medical student. And I would go down into the reading room for any of my rotations, right? You always started in the reading room. And it looked like this, right? There were alternators everywhere and dictaphones. And while the rad was not sitting on the desk in general, everyone through. And why was that? Well, it's because no one had access to the images, and it would take days for anyone to get the report. And with that, no matter what rotation I was in, there was just this wonderful, robust clinical discussion between two physicians, the caring team and the radiologist. And I was so impressed with the radiologist that they were able to speak with everyone and provide this wonderful consultation that I knew right away that I needed to go into the specialty. But that was a very long time ago, unfortunately. That was back in the 90s. And these days we have PACS. Actually, when I started residency, a first year of residency, we had PACS. And I thought it was going to be like it was when I went to my medical school, and that I'd go into the reading room and it would be the exciting place. Everyone would come down. There was like the Starbucks of the hospital, right? You go there before you do anything to get your morning coffee. Well, to get your morning read and your morning consultation, you do that. But when I started residency with PACS, it very quickly became a very quiet reading room. And that changed. It really changed how we practice medicine. It changed how we practice radiology. Now, there were some good things about it. PACS, this is my home workstation. It allows us to read from different locations. It allows images to be available digitally to other people with voice recognition. Of course, they also have access to our report. And it also made us more efficient. And that was really important back then. Here's a growth curve of just imaging services in Medicare from the time that I was really starting in residency or an internship all the way through the next 11 years, growth of imaging services increased by 80%. It's just a massive increase, and that increase has not stopped. Unfortunately, the number of radiologists has not grown in the same way. So we only grew by about 25% in terms of radiology staffing. So we need to be more efficient. But even efficiency on its own that we gleaned with PACS was not enough. And so what do you have to do when you don't have enough people to do all the work? Well, you try to do it faster, right? You run faster on that treadmill. And if you're not being more efficient, you're just trying to be faster. There's no way to do it at the same level of quality. It's just not possible. But you have to get through the studies, so you read faster. And with that, you lose some of the value that you had provided before. And I'll say that some of the value was lost already, because with PACS on its own, that robust clinical consultation was completely lost. And it was transitioned to whatever history we could get from the risk field. And that's a certain size. And suddenly that wonderful discussion about the patient presentation became abdominal pain or trauma, please evaluate. So that already was not helpful. And then on our end, what did our consultation become? Our consultation became an electronic piece of paper. And you just can't communicate in that same way. So we'd already lost some value. We then had to read faster. So what do we want to do? We need to go back. We need to go back to the time where we provided that wonderful consultation, where we got it that wonderful history, right? Where the doctor's doctor. Let's go back to that time. But we can't go back into the past. We're not going to wait until everyone comes back into the reading room and takes the time to do that. We need to use technology to do that, but with a future state technology. And I think artificial intelligence is going to bring us there. It's really not about artificial intelligence on its own, the hype that everyone used to hear about it replacing us. It's not about that. It's about how we can collaborate together. There are some things that humans are wonderful at, and some things that computers or systems are wonderful at. And if you put those two together, you should get better than either one alone. So it's really about a human cybernetic collaboration, and also a collaboration because we are very early on in the maturity of this technology and its use. Standards are not defined. And without standards being defined, you need a really close collaboration between the vendors and the academic centers or private practices that are using these technologies. Okay, so today we are going to go through a rainbow of lessons learned in things that we've seen in deploying AI at scale. And so to get started, I want to think about, where are you deploying AI, or how do you think about where to use AI? And the best way to think about that is to split up radiology into its different components. And hopefully you guys have seen some version of this. I think Curt calls it the life cycle of an examination. But it's the idea that we're involved in more than just interpretation, detection, and diagnosis. We're involved in every moment from the time that an ordering clinician has a clinical question, and the vast majority of time they want to do imaging in order to figure out what's going on. Scheduling, protocoling, acquiring images. We don't read the raw images, we read reconstructed images. Then those images come in a work list, and how do you make that more optimized? When you open up that exam, the next patient, the patient information comes up. Well, how do you get back to that more robust consultation or better information about the patient? And then when we do a look at the exam, detection, diagnosis, quantification, segmentation, all of those things that we're doing, report, communicate, and then following up with a patient and peer learning. Every single one of these segments can be benefited by AI. And I will tell you, they already are. These are different kinds of AI algorithms that are available on the market, whether many are FDA cleared, some are not. Everything in yellow is something that we in our organization have either trialed or implemented or created. And so a lot of the learning lessons that we're going to go through today are coming from these components. Okay, so let's start with some deployments. How much have we actually done? Well, we created our own NLP algorithm, and we'll talk a little bit about it later. We created it in 2017, started deploying it in 2018. It's now been deployed to over 1,200 radiologists in our practice. We've also run an NLP we have these best practice programs to make sure people are recommending the appropriate follow-up. And we have a follow-up program to make sure that the information that we're recommending is getting to the hospital. Literally run that on millions of reports We have also trialed a tool that does an automatic impression generation. And when we do trials, the trials tend to be big because our practice is big. And so we did a pilot with 150 radiologists. We have also now deployed 7 different CAD-T, that's a triage algorithm, and we'll be talking about that next. We deployed 7 of the CAD-T algorithms, and they're available across 15 million annual images and growing. So with that, we've got a bit of experience. So the first thing I'm going to talk about is CAD-T. So what is CAD-T? CAD-T is a triage product. It's an artificial intelligence product that's usually doing some kind of detection, usually detection for a critical finding. And when it does that detection, it's able to mark a study that it reviewed it and thinks that there's a positive finding. And when it's then put on your work list can sort by the priority of these critical findings so that critical findings get moved to the top of the work list. Now, when these first came out, and one of the reasons why they first came out was because it's probably one of the easiest things to get through the FDA. So there was an easier path to FDA clearance. When they first came out, there was not a huge amount of excitement about it. I mean, hey, it's great to be able to move pathologic findings to the top, but we read a lot of our studies on time, especially if they're stat. I mean, unless it's a stroke where time is brain, if you read it in 7 minutes or 9 minutes, is it really going to make a difference? You know, it would, in theory, make a difference for inpatients and outpatients where you're not reading them for a longer period of time. But the amount of pathology for those critical findings is a lot less on those patients. So we actually ran a pilot with 2 different CAD-T algorithms. We ran it over 6 months back in 2020. And we actually found a few other benefits besides just getting to an exam faster. We actually found that reading all of those exams
Lost your audio?
non-contrast head CT exams, we were reading them all faster. So what did that look like? And why is that? I mean, it's kind of interesting. You'd think, all right, if it's pointing out a pulmonary embolus or an intracranial hemorrhage, maybe you'd be a little bit faster in reading that. But what about all the other pathology? It's not pointing out any of that. Like, why would you get faster? It ends up that you don't actually get faster. The speed, the increased speed on reading these exams is not related to how much faster you are on positive studies. The incidence of these positive studies, like pulmonary embolism incidence for us is about 7%, and intracranial hemorrhage about 5%. So there's no way that 7% or 5% of your exams can really affect the overall read rate. So what happens is it's related to your negative studies. And if your algorithm is sensitive enough in detecting the positive exams, if the negative predictive value, when it says it's negative, is high enough, then people develop confidence and they don't end up looking at those studies and maybe a second or third time looking for really subtle findings that they might have missed. And that's what caused the reading decrease. So we were more efficient by about 10% overall. What else happened? Well, it made us more sensitive. We know we're humans and that we miss things. So for pulmonary embolus, we found that we were able to increase our detection of these by about 4.4%, and for intracranial hemorrhage, 2.4%. And the images on the bottom are actual things that we had missed, and they're fairly representative of the types of studies or types of findings that were being missed. They're subtle. Like the pulmonary embolism one was an isolated one, and while it is in the lower lobe, in this case, which is a more typical location, it was isolated and it was subsegmental. And the intracranial hemorrhage that was here, it's like so small you can barely see it, especially next to the calvarium. Even when you change the window levels, I mean, it's visible, but it's very subtle. These things are really easy to miss, and that was typical. The algorithms were helping us find the more subtle findings. And so what we should be doing is we should be asking ourselves, is that important? And we've been missing these findings over time. And this is not just radiology partners. This is overall in radiology. As humans, we miss some of these subtle findings. Is it important? What if I found all of these cases and maybe treated all of these subsegmental solitary PEs or hospitalized all the patients that had these tiny, tiny intracranial hemorrhages, am I going to actually improve patient care? Maybe I'll increase the cost of care. Maybe I'll cause more problems by treating than I would by having the benefits of that treatment. We should think about that. And I think as we get more information about what happens to these patients, we'll be able to determine statistically what to do. And I think our goal over time, as we run this program more, is to be able to help triage these patients. Which are the ones that we think will need to stay or be monitored or be treated, and which are the ones that can go home? And I say that because we do already have a couple of anecdotal cases, and here's one of them. So this is a 72-year-old female. She came into one of our ERs. She came in with altered mental status, no history of trauma, and she was not on Coumadin. She's not on blood thinners. And there was a really small acute subdural hematoma along the left temporoparietal lobe that was missed and caught by the AI. So we ended up calling that patient back. And when she returned, it was about 36 hours later. This is what happened to the hemorrhage, like massively increased in size. And even though she was 72 and had some volume loss, just this increase of the hemorrhage caused enough mass effect that it compressed the left lateral ventricle, it caused left to right midline shift, and it was sufficient enough that she was symptomatic and had to have a craniotomy. So just because these findings are really subtle, it doesn't mean that we can ignore all of them, and we can't always anticipate which ones will go on to increase or to cause problems and which will not. Hopefully we'll get more of that data over time and we'll be able to triage these patients better. Okay, the last thing we found was that our rads, well, one of the last things is that our rads really enjoyed using it. You could have the best algorithm that drives the most value. It does not matter at all if your rads don't like using the tool. And if you have not heard of the NPS score, it's a net promoter score. It's basically one question that we ask to our radiologists. And would you recommend this to a friend or colleague? They grade between 0 and 10. And then you get a score between -100 and +100. And while a 64 sounds really low for those of us that are high achievers and used to getting a 60 being a D, it's actually a really high score for an NPS score. It's up there above Amazon. And so our rads really enjoyed using the tool. In fact, when the 6-month pilot was over, they asked us to not turn it off. And this was, let's see, mid-year 2020, and we've kept it on ever since. All right, last thing that we learned was it was a really fascinating way using artificial intelligence to facilitate peer learning. And I'm just going to go through some images so that you can see, but what I'm going to show you is the peer learning where the rad's missing a study or missing a finding. It's a great way to do that. But there's another component of peer learning too that's really important, and that's to also teach the radiologist what the AI is missing or overcalling, because that's the only way you can get the radiologist, the human, and the AI system to work better together. But let's go through an images example. So I just wanted to take something visual. So in chest x-rays, the reported error rates are, gosh, up to 40%. So let's just take a 20% error rate. It doesn't mean we're missing giant things 20% of the time, but we tend to be missing some things. So here are 190 different chest x-rays. And if the error rate is 20%, 20% of 190 is going to be 38. And that means that in this constellation of 109 chest x-rays, there's going to be 38 errors of interpretation. Now, if you're doing a standard peer review where you review 3% of cases, statistically, you will be reviewing 6 cases overall, right? 3% of 190 is 6 cases. And statistically, you'll be only finding 1 error because 3% of the 38 is only 1. So what is that going to look like? Here are your 38 chest x-ray errors in red. And as we come down and review 6 of those, statistically, only 1 of them is going to fall on a positive missed finding. And what does that look like? Here's your 38 errors. Unfortunately, you are only finding 1. Now, let's say you review 5% of cases, because you might. what is that going to look like? Here's your 38 errors. You actually only find 2. So you're really not getting a lot of opportunity from lessons learned from this, because you can't possibly review all of these cases. And we know that because we're doing a traditional peer review where this information goes back to the hospital and could affect us from a credentialing standpoint, a lot of times people will ignore the positive findings. So you may not even get these 2 positive findings as learning lessons. Now, what happens if you have AI reviewing studies? Now, AI can review 100% of the cases. Now, I know AI right now is pretty narrow, and so you're only looking for a few findings, but that is already starting to change. There are AI algorithms out there in chest X-ray that look at 40 findings, or one that looks at 124. So more robust AI review is going to be available soon. Now, it's not all 100% sensitive. It won't pick up every exam, but let's say it's 95% sensitive. So here are your 38 chest X-ray errors. We are able to review 100% of them. 30 of those 38, we will get a 95% accuracy. And that gives us 36 AI-enabled learning lessons. It's a massive amount of peer learning that we can use to educate ourselves. And as Curt said, my first job after residency was actually going into a company where everything I did was prelimmed. I was living in Sydney, so you couldn't read anything final. And that meant 100% of my exams were overviewed. And I went straight from residency to this. I learned so much in that first year. It was like the best fellowship I had. I got follow up on every single patient. I found out when anyone disagreed with what I was saying. And I started changing the way that I read. I noticed I was missing midline subdural hematomas. So even now, when I read head CTs, I look first along the midline as I go up. And when I come back down, my search pattern is more external. And so this is really a wonderful way to help educate us about some of the things that we're missing. Okay, so second lesson is it's really important to invest in RADI education. And I think that's something that we need to start now. We have to remember that AI is a clinical tool. It's not a technology tool. This is very different than rolling out a PACS upgrade or rolling out an upgrade in your VR system, where you can do that just with IT folks. You have to do this in a more robust way. And it's not something that it's something that we're used to. We've done this before in the past. So think about, if anyone remembers when MRI first came out. When MRI first came out, there was a lot of hype. Everyone can see everything in MR, and we're not going to need radiologists anymore, right? Sounds familiar. Well, with that, the reason why we are still reading MRIs today is because we took the time as clinicians to become the local experts. And as the local experts, people come to you and they ask you for your opinion. And I think we need to do the same thing with artificial intelligence. If we invest in artificial intelligence now, then we're going to become the local experts. And with that, because of the maturity of where we are in this technology, we'll be able to drive where the technology goes. And I think that's so important. We are the imaging expert. We're technology experts. We're workflow experts. And if we become AI experts as well, we can use it in the best way to drive the best outcomes for our patients and as well for our clinicians. Now, we can choose not to do that. We could passively consume the technology and then sit in the backseat and have no control over where we're going in the future. We could also ignore the technology completely and get driven over by the car. But I would argue that both of those would be a disservice to our patient population, to our clinicians, to ourselves, and radiology overall as a specialty, and with that, healthcare. So we're lucky in radiology. We actually have the opportunity to do a lot of learning now because there's a huge amount of information that is out there in radiology, more than in any other specialty with AI. And I'd encourage you to take that time when you're an early learner or an early adopter to just learn more about it and become the early expert. It's developing that expertise that's going to let us drive where this technology goes in the future. Okay, so I am just looking at the chat. That looks okay. I'll answer that question later. So what are we doing in our organization to manage this? Education takes time and effort. The way we have started is we have created a cloud native platform that houses some different AI algorithms. And we have about 15 million plus images and reports that are available to this cloud native platform. And what we do is we send both of those into the platform, the AI interprets them, and we get an interpretation both of the computer vision results, but also using NLP of the reporting results. And whenever those two are discrepant, we take that discrepant information and we send it to a peer learning system. And the discrepancy could be that the RAD missed something that the AI picked up, but it could also be that the RAD mentioned something that the AI missed. And both of those are equally important. You know, you have to remember with the FDA clearances these days that algorithms are basically frozen in a point of time. And so if they're going to make a mistake on a certain type of exam today, they're going to make that same mistake tomorrow. And so you want to educate your radiologists so that they really understand when they can trust the AI and when they should more trust their own thoughts about any pathology or finding. So we pass that information to our RADs. We also pass that information back to our AI systems. Now we are doing 15 million exams today. We're continuing to add more studies to it. So just we have a massive database that we can roll out to our radiologists, create tons of teaching files, and make sure that our radiologists are educated. And to me, that's the way that you need to, in order to get our radiologists the expertise in something that is really clinically novel to many of us. Okay. So I was telling Curt, I just added 3 slides like 30 minutes ago, and it was these, because I was realizing as I've done a lot of change management in our practice over time, right, with so many radiologists and rolling out clinical programs, whether they're AI or not, there's a lot of learning lessons that you have. And I just wanted to go through 3 of them. And one of them is sort of about a mathematical concept of reverting to the mean, that whatever your average is over a long period of time, that even if you deviate it one way, you tend to revert back to the mean over time. And this happens with education. So as we start educating our radiologists on how to use this, if you don't continue that education, they're going to revert back to their mean. And their mean right now is not knowing that much about AI. And so you can't do a clinical education as a one and done. All of these are continuous things that need to happen over time. Okay, second lesson, Edward Deming. He's an American statistician, and he has this famous quote, "In God we trust, all others must bring data." And we found this to be very true in our organization, that if you try to change something, but you don't follow up with some information about who is changed and who is not changing, that you'll end up deteriorating over time. Just humans, we do that naturally. And so here's an example of a scorecarding process that we implemented to manage a clinical rollout of what we call these best practice recommendations. And it was just a way to decrease variability in our reporting. It was many years ago. There's more white papers out now, but it was really kind of related to the white papers and ensuring that when there were certain kind of findings, that everyone recommended the appropriate follow-up for population health. And in the beginning, before we even had any scorecards, you teach people something and they do pretty well because you're teaching them 1 or 2 things and it's top of mind. But what happens over time is their performance is going to deteriorate, and that's just human nature. And until you start putting in something that shows people how they're performing. So in June, we implemented this scorecarding. So all of this data that I have here was retrospective. We didn't have scorecards till June. When we implemented scorecards and showed that to people and shared it to people and made it part of our workflow that they were looking at it, scores increased. And this is going to be true with artificial intelligence as well. I think that you do need to do continuous learning, but continuous learning on its own may not be enough. We may need to do a little bit more in just showing who's using the technology and who's not. Okay, last learning lesson is that it takes an army. You know, you would think that that it just takes so many people to get information out to a very large practice like ourselves. And I'll tell you that in some ways, maybe that's true, but the people that have the most effect on being able to educate the radiologist about what they're doing and make sure they're using it is not the army of people that we may have centrally in our practice. It's the individual who loves artificial intelligence, and we've taught them about it, and they are going to champion it within their practice. It really only takes one person. If you have one person that is local in your practice that you can educate, and they will then disseminate the information, you're going to be far more effective than any army of central people. I mean, who has influence in the practice? It's the people that you're working with. When you ask humans, like when you ask people, who do you look up to? Well, it's generally the vast majority of people, it's someone they know. It's someone they know closely, their dad, their coach. It's probably not Oprah or the president or someone else. It's someone that they're close with. So you have to take that same concept and apply it to education. Okay, let's look at the next product that we created. This was actually the first one we did, and it was related to reporting using NLP for the radiologist report. And with that, the third yellow learning lesson is that AI needs to be integrated into the RAD workflow. Now, I say most, and I put it in parentheses for a reason. AI really does need to be integrated into the RAD workflow. The problem is with the current technology that we have in PACS, most of the time we can't do that. We can't do it in a really integrated fashion. We can get away with some of the AI not being as fully integrated as you might think, because it's just not possible. So that's why I say most and most in parentheses. So here's the technology that we created. It's called RecOMD. We created it just for our practice because I had showed you before, those scorecards were about radiologists trying to remember what is the appropriate follow-up for any best practice. And that was hard. It's hard for humans to remember things. It's not what we're good at. So we created this AI solution that would gather information about the patient and the exam, all of the metadata, and then it would listen to the radiologist as they dictate. And as they dictate, it would combine that information, remember, it would already remember that there's a best practice, and then it would provide that best practice for them. So what does that look like? So here is a mock-up of what it looks like. The solution is in the upper right in blue. And in this patient, we're looking at a chest CT, and there's a thyroid nodule. So if you go ahead and you would probably, first thing you would do as a rad is you would measure that nodule. Now, RecOMD is an NLP solution. It's not looking at the images, it's listening to the report. So until I put something in the report, it's not going to react. So if I dictate there's a 1.2 centimeter nodule in the right lobe of the thyroid gland or anything like that, then RecOMD will recognize it. It's extracting the relevant information that it's 1.2 centimeters, and it's combining that with the patient age being 53, and it's providing me with the best practice recommendation for that thyroid nodule. Now, how do I say it's integrated? Here it is separate from the voice recognition. It's sitting up on top of it. Well, it's integrated because if I make a change to anything, and here I realize, oh gosh, I actually measured the top of that nodule. Let me remeasure it. It's actually 3 centimeters. Let me redictate. If you redictate, even if you just change the 1.2 centimeter to 3 centimeters, immediately the tool will then reevaluate the exam and the pathology, and based on that provide you a different recommendation. And in this case, it's completely different. In this case, you would want to recommend a thyroid ultrasound. So that's what I mean by integrated. I mean that when you do something, whatever you're doing, whether it's in your voice recognition system or if it's a computer vision tool, when you make a change, then the AI reassesses it. Okay, we do know in radiology that workflow is absolutely everything. Some of the findings, maybe they're triage or incidental findings, critical results. If they're not fully integrated into the workflow, you're probably okay. We run right now the CAD-T. When we did our pilot with it, we didn't integrate it at all, and it still made us more efficient. All of those findings that I told you about, they all happened without any integration, so you can still get some benefit. When you come to something like oncology evaluation in AI, in that case, there's just no other choice. You need a really robust and feature-rich, very integrated AI. And what would that look like? So here's an example. The current study is on the left and the prior study is on the right. And I want to show you what an integrated solution would look like. So here's a video where the AI, as you're scrolling through, it's actually finding the lesion. And then you as a rad can say, yes, I agree with it. It detected the lesion. You agree. It will segment that lesion for you. Here's another case. The current study is on the left of your screen, the prior study on the right. Now, in this case, the AI didn't see the finding. So you scroll through, you can see the nodule, but the AI didn't pick it up. The rad can click on it, and then it will segment that pathology. Now, you could change the size of it. And with that, the AI should reevaluate the nodule, not just based on the size, but any other characteristics that you're looking at. And then it should reassess either the risk or maybe the lung rad score and provide you with a new input. That's integration. That's human cybernetic collaboration. Unfortunately, with our current technology within our PACS, it's just not really possible to do that. So if we can't have AI integrated directly into our PACS in the way that we want, what can you do? There really are 5 different options available right now, and they're still useful. There's 3 ways to send an AI result to PACS, and there's 1 way to call an AI viewer or to embed it into PACS, and let's take a look at what those look like. Okay, so option number 1, how do you send AI results to PACS? Well, there's a few ways. 1 is through a DICOM secondary capture, and that's basically like a hard copy of the image with the pathology sort of frozen into that picture. It's almost like a PDF. And then you can take that picture and put it as a separate series so that you can pull it up wherever you want in your hanging protocol. It's available now, which is wonderful. And the downside is, and it makes it easy for the rad to actually see the results. At least you get access to the results. The downside is you can't edit any of the annotations, and they are sitting there. Now, your PACS may not be, everything in your PACS may not be part of your medical record. Maybe it is, but certainly referring clinicians or perhaps in the future patients might have access to this. And if they haven't learned about the technology, it may be hard for them to understand. Maybe you disagree with what it says, and yet that image is kind of sitting there burned in. So it's possible, and it's 1 way, not optimal. Here's another way. It's called a DICOM SR, so structured report, which is essentially a way where you're taking information from the AI system and you're passing it to your PACS, and your PACS overlays that onto the actual image. And the good thing is that when it does the overlay, it's very well correlated with the underlying image. So there's no chance that you're going to overlay on the wrong information. PACS can do this now. This is how CAD has been implemented. And what's nice about it is you can toggle it on and off. Now you still have the same issue where you can't edit the annotation and anyone can see it, and it could end up being part of your medical record, but it is available now. 3rd is called a presentation state. Now you might have heard of like a GSPS, which is called a grayscale soft copy presentation state. That's one of the most common terms and ways of doing this that I've heard. Now you can do this in your PACS. It is an image overlay with the information that is from the AI system. The good thing about it is you can actually edit the annotation on it. You can make any changes you want. The problem is that these systems, these presentation states are proprietary, which means that if you go from one PACS system to another, there's going to be very poor interoperability. You likely can't pass the information from one system to another. And the correlation with the underlying image is not as good as it is with the DICOM SR. So it is possible that it could overlay on the wrong study. All right, option number 4 is to have a separate AI viewer interface. So you would just push a button on your PACS and it would open up a completely separate user interface. And that's what I was showing you before when I went through those videos. It was another vendor that has a user interface that is ingrained and embedded with their AI. And it's really wonderful. Now, this is probably how you do some things. It does take you out of your looking at your main viewing screens. But at least it's available and you can be interactive with it. And there are several AI vendors that do this, not all of them. There's only a couple right now. And you have to make sure that that system is context aware. So when you click the button to say, hey, show me this image somewhere else, and it's usually just a web viewer that it's pulling up, that it's showing the same patient. You don't want any risk that you're going to bring up a different patient. Usually not a problem. It's just that not every AI solution will come with a viewer that can do this. All right, and last option is if you took that same viewer and you just embed it into your PACS. Now, some of the PACS can do this, many cannot. And those that can are not always that, they don't always want to do it, right? Why do they want a viewer that's inside of their viewer that can actually do more than they can? So a lot of the PACs will be reluctant. I have not seen really anyone do this, but it is possible in some systems. Okay. So lesson number 4, we're down to green in our rainbow, that you need a platform in order to deploy artificial intelligence at scale. And there's a benefit to that, and that's automating workflows. So I really like this quote from Carl Sagan: if you wish to make an apple pie from scratch, you must first invent the universe. And I found this to be true in artificial intelligence. If you ask any of the vendors, how much time do you spend on creating the algorithm versus how much time do you spend on doing everything else that surrounds it? And it's generally 85% of their time is spent on the everything else. And in deploying, it's the same way. And I started learning about the everything else when I started learning about something that is called orchestration. So I just wanted to share some information with you about what orchestration is. It's essentially the purposeful and hopefully automated movement of data. So what does that look like when it comes to AI? It means that you've got data that's going into an AI system. It comes out with some structure from the AI, and then it gets sent downstream. Orchestration are just the arrows. It's the movement of data in a purposeful way. And as we've done this, I've started to learn more and more about the different components. The first component is sending your data to the AI system. And there's 5 lessons we've learned in that. I'm just going to give them to you because we don't have time to go through all of them. But we have learned that it's essential to make sure you're sending the right study to the AI, but it's not just the right study, it's actually the right series, or maybe even the right image of the right study for the right patient, to the right AI algorithm, and doing that at the right time. It's actually fairly complex when you get down into it. And I'm going to show you just a couple of the basic examples. But the more you learn about this, the more, I think, the more fascinating it is. And the accuracy of how well you can orchestrate your data is going to affect the accuracy of your overall AI result. So here is a online bone age algorithm, right? No bone age algorithms are FDA cleared right now, and this one is not. But it is online, and it won, I think, like a Kaggle competition. It's a really great one. So I decided, let me play around with it a little bit. I sent this left-hand PA algorithm or PA image in a child to the algorithm, and it gave me the predicted bone age, standard deviation. Wonderful. It was everything I needed, and it did it in 1 second. Awesome. So what happens when I send it this mammogram flipped on end? Well, it interpreted it. Right? It told me that it was a 13-year-old male. And if you send it data that it's not expecting and hasn't been trained on, it's not going to do a very good job interpreting it. And if it doesn't have a way of filtering out the right types of exams, well, then you're going to have to. If you knew that this study, or if the system knew that the study was a mammogram, it never would have sent it to begin with. Here's another one. We actually have 2 different PE algorithms that we use. We use one on very high quality studies. Usually a CTPA is high quality. It's meant to be a PE study, but sometimes the timing is off. So anything where it's a high quality study, we'll send it to one algorithm, and then another one where it's either a mistimed exam, or you're doing a chest CT on a different phase of contrast, or maybe an abdomen pelvis for trauma and you're catching the lung bases. We'll send those to an incidental PE algorithm. Well, how do you know which one to send it to? If you send the right study to the right algorithm, you're going to get better results. A lot of the way that people orchestrate data to an AI now is they just look at the DICOM tag. They say, oh, this is a CTPA. It's a CTPA. All of my CTPAs go to my high quality CTPA algorithm. Unfortunately, that might not be the best way. If you knew that the Hounsfield units in the main pulmonary artery were a certain level, you could make a different choice. And that different choice is made based on knowing the piece of data. You need to know something about what's in your data. Okay, so this is our data orchestration. We have 5 lessons that we've learned about that. And it really, the key I want you to remember is it's about knowing a little bit about what's in your data. So what does that look like? Instead of sending the data immediately to your different AI systems, you have to sit an orchestrator in the middle. And that orchestrator, if you know something about your data, needs to figure out some things before it determines what AI system to send it to. Okay, so if orchestration needs to know what's in your data, how do we do that? All of our data is unstructured, right? how do we figure out what's in our data? Well, we have a couple of ways, but I'm going to suggest lesson number 5 is that we use AI. And one of the most wonderful things about AI, even if you just generalize, what does artificial intelligence do well? It's wonderful at adding structured, unstructured data. It doesn't need humans to do it. So how can that work? Well, instead of going back to our life cycle of an exam, this is kind of sitting outside that area, and it's using AI to better manage the data that we have. Right now, I think in many organizations, we use a lot of humans to do some data mapping. Well, let's try to do it a different way. So what does that look like? Here we have some unstructured data on the top of the image. We've got images, or top of the screen, we've got our images and reports. And how do we add structure to that? Well, we have DICOM and HL7 standards. Those standards tell us information about what is in the image and what is in the report. So I'm kind of showing that as these blue ovals that are attached to the image. It's providing us some structure about that study. Now, the problem is they're not always going to be right. You may even be getting information about your DICOM from your HL7 order. Some people don't even look at the DICOM header so much. They're using what was supposed to be ordered to tag what is really in there. And the other problem is that it requires a lot of humans. And although these are standards, not everyone follows the standards, and the standards are not perfect. And so you get a lot of crazy data. And if you get data from all different places, you have to normalize it to a standard for you so that you can use it at scale. And that takes, unfortunately, a lot of humans. So what if we thought about it in a different way and said, well, maybe AI can do this? If you employ AI to do it, well, number one, you get way more data to start with, because you could have any number of AI solutions. Maybe there's one like we have that looks at the Hounsfield units in the main pulmonary artery. Could be another that looks at the study quality of the exam. There's another one, one if it decides what's the technique, is it using oral contrast? Maybe one that tries to figure out what the CPT code should be. Tons of information. I mean, we're just only limited by our own ideas and the algorithms they create. So using AI can provide much more robust information about what is in our data, number one. And number two, it can correct some of the information that may be incorrect through the DICOM or HL7. So I think that's a really exciting way to use AI, and we're starting to do that this year. There are some AI companies that do that a little bit themselves, but you ask the vendors, it's just a fascinating use case for AI. All right, let's go back to our orchestration. The second part is sending the AI downstream. In general, we think about sending the AI just to the radiologist, right? If maybe it's going to the PAC system, to the viewer through your secondary capture, or maybe it's going somehow to your report or through some user interface, a widget that the vendor has. Generally, we're just sending it to one place. And I would argue that if you knew a little bit more about your data, you can make better choices. You don't have to just send it to the radiologist. There's lots of different places that you could send it to. For instance, if you didn't have reconstructions, you had an algorithm, an AI algorithm, and it told you, hey, I'm missing my reconstructions on this CTA. Well, you're not going to want to send it to the rad. Why don't you instead send it to your technician that did the examination, the technologist that did the CT scan, because they're going to be able to go back and do that. And why waste the time of the radiologist while we're waiting for this? Now, the more data that you have, again, the more information you know about the data, the more you can do. Maybe you can make a choice about sending something to a reporting system. Maybe you're picking out the technique and you could automatically pre-populate the technique in our report. Maybe you have that information and you know which PE algorithm am I going to use. Maybe you have some data that you've looked at the report and there's some information that needs to be followed up. Maybe you could send that to your referring clinician. If you have an exam quality issue, you could send that to your technologist, or you could also send it to your reporting system and put in a section in your report about the exam being low quality. You are really only limited by your own thoughts on what AI you can create. And with that, you can have massive amounts of places to send it to. And it's not just sending it to one. You could send it to one and then have it go downstream to 10 other places, or you could send all of these things to different locations all in parallel. So what does that look like? Second part of orchestration is the AI system goes to an orchestrator before it gets sent downstream. And it's not just limited to your work list, PACS, or VR. If you know what's in your data, you can send it to multiple other places. All right, we're getting a little close on time. So let's see, I might just show you a couple more things and maybe we can come back at another time and do some more lessons learned. But I'll go through this one. Orchestration is only part of the solution. There's something that you need to do that is beyond orchestration, and that's a platform. So here you have your orchestrator that can send the data to the AI. Well, there's all kinds of other things, normalizing the data, translating it. And if you create a platform, well, it orchestrates the data, but it does all of these other things as well. What does it look like on the other side? Well, on the other side, your AI is creating structure from unstructured data. These are these blue circles that are blue ovals. You want that structured data to go to you in a place that you can use it. What happens with that now? And this is probably the most important insight that I had as I started learning. The way that we deploy AI right now, that information is either just going downstream to our work list or our VR system, or it's completely disappearing and no one is taking advantage of it. It is insane that we're getting structured information and we are not attaching it back to our data. So if you have a platform, all of that information, that structured data, then gets captured and attached back to your data. So you can decide where you're going to send it to in a really smart way. All right, so a modern platform should have all of these things. In my opinion, it should be a cloud native platform. We have created one. I don't think I have time to go through it today, but I can always come back and talk to you about it another time. Let me close by just finishing up here. Sort of a really nice quote from Steve Jobs, and Apple did a great job at this, that if you don't cannibalize yourself, then someone else will. And in radiology, we've recreated ourselves multiple times. And as Curt famously said, rads or even practices or hospitals, systems that use AI will replace those who don't. And that's our final lesson of the day. My interpretation of radiology in the future in our really tech-enabled land and AI and data-enabled land is that we're going to be different than we are today. So excuse the picture from my Minority Report and pretend Tom Cruise is a radiologist. But the idea is that you want to be working with all of the data we have, not just the data from imaging, but data from radiomics, genomics, molecular imaging, AI, all of that is going to be providing more and more information to you. You should be able to work in a system where you can change any of that information. The changes you made should get then reevaluated by that system. And then you go back and you have to provide the context. And then with that context, you provide your robust consultation back to the referring clinician and perhaps also the patient as well. With that, that is a fully integrated system. And how I think we'll practice in the future, we will not just be the imaging expert, we will be the information expert. One final lesson is, it comes from the German Kaiser Wilhelm II from back in the time when automobiles first started coming out. I do believe in the horse. The automobile is no more than a transitory phenomena. I think we can't bury our head in the sand. We don't even want to sit in the back seat. This is something that we need to grab by the reins, learn about ourselves so that we can change who we are as a radiology practice, as a radiologist, as a profession, so that we can drive this technology into the future to do the best for our patients. So with that, in summary, we talked a little bit about some of the AI that we use at Radiology Partners. We went through 6 learning lessons along the way of things that we've learned as we've started to deploy. And with that, I think the most important one of all is to really invest in rad AI education. Make sure that we start to learn about it. It's not a scary thing. It's a wonderful thing. And we can become the experts and start driving where this technology goes. So with that, I will pause because I think
Thank you so much. Thank you. That was a tremendous tour de force. It just goes to show we all have theories, but like the quote that you showed, there's no substitute for data, and really there's no substitute for doing to learn some of the implications of implementing these technologies. So thank you so much. There are a number of questions in the chat, and we just have limited time. So I'm just going to go through these in order, and we'll try to do them as rapidly as we can. So the first question just relates to the mismatch between the products that are available, vendor products that are available today, and the things that radiologists actually need. Tell us, what are your thoughts on that? Do you think that is a disconnect? And what are your thoughts on, is that going to resolve soon as we get more and more clinically driven AI applications?
So I do think it is a disconnect. When the algorithms started coming out, people were taking advantage of the data they had access to and what they thought a radiologist did. So a lot of the stuff was related to image detection. And frankly, I think our detective capabilities, our visual cortex is very well defined. It's probably not the thing that we need the most, but that's starting to mature, and people are starting to realize that there's more AI vendors that are working very closely with radiologists and systems. And so you're starting to see things that are definitely becoming more useful that are out there. And that's just going to continue in the future.
Great. And then David Larson asks about, highlights the peer learning activities and asks, could this be used to find great calls, not just misses? Have you explored that?
We actually haven't, but it is a wonderful idea. One of the terrible things about peer review is it's so punitive, and even peer learning, it can have a negative connotation if you're just always trying to realizing how much we actually miss. So finding great calls, yeah, I think it's definitely doable, because the AI is detecting things that in some ways I thought are pretty fantastic. And so you could really take that subset of cases and find the times where the RAD mentioned it as well, and use that to point out these great learning lessons for good calls.
Mm-hmm. And then Ala Youssef asks your thoughts on human-computer interaction. So as we have more and more algorithms all operating on the same images, you can imagine a kind of cacophony of things happening. How do you plan on handling that?
It's one of the reasons why you need a platform. You need a platform for making sure that you can orchestrate the data to the right AI algorithm, or to multiple AI algorithms, and then consolidate that back. And you need a mechanism to take all of that information and pass it back to the radiologist. You don't want a whole bunch of just different series from a bunch of different AI algorithms, and you don't want a whole bunch of widgets. That the platform can help with that.
Great. And then David asks, how much do you develop in-house versus vendor products, and how much development do you have to do around vendor products? The kind of, we used to call it spackleware, kind of putting the pieces together.
Yes. So the first time that we were looking at creating a product, it didn't exist. So we went externally and we hired some data scientists to create it for us. And it just so ended up that after working with us on the project for about 1.5 years, they came and joined our practice. So that group of 4 external data scientists are now part of our team. We now have 8. And they tend to work right now on natural language processing. They've done about half of the work. They don't have a lot of experience in computer vision, so we've gone externally to do computer vision things. How much of the time have we had to manipulate it to make it work for us? We haven't had to change the AI system itself. The one, we've picked ones that are specifically quite accurate, but we have had to make some changes to how that information is displayed and to make sure the RADs are using it. And when you try to incorporate it in the workflow and all of the education that goes around it, which is a huge effort, all of that is sort of the spackling that you have to do.
Mm-hmm. And then talk about the method for developing the algorithms, supervised versus unsupervised. If you do any algorithm development, you could address that, how some of these semi-supervised pre-training methods and so on. And then the other is a question about adversarial attacks. Have you thought about that? I assume your systems are quite secure, so you're hoping an adversary doesn't get in, but what are your thoughts?
Yeah. Okay, so supervised, we've done all of the stuff that we've created has been with natural language processing, and we do tag our data to do that. So it's essentially supervised. We're not using radiologists, however, to do that tagging. We're using clinicians, data scientists, sometimes interns, and the data scientists are leading that effort after learning from us, but it's not requiring radiologists. we found that that provides us the best kind of output. You can do some clustering analysis where it's not being tagged at first, but we have not gone into that and had experience with that ourselves. I think Curt actually has a lot of experience with that. If you have a lot more data, then it doesn't need to be labeled as much. He's the expert there. The other one is about adversarial attacks. We have a whole division on security, and it is becoming more and more important. A lot of the security efforts are related to, frankly, education to our radiologists and support teammates, because a lot of them come through emails. So phishing is one of the most common, and we do a lot of education, and we actually send out phishing emails to our own teammates to see who answers them so that we could educate around that. And then we have a lot of software that we use. There are some really good ones that have helped us. And when we look back at how many attacks there have been, it's crazy. Even in the data center, we've been in a data center where one of the big airlines was in the same data center and they got attacked. And because of them being attacked, it affected not our data, but it affected how just the movement of data and everything went down for a while. So you can be affected in many ways, whether it's directly or indirectly, and you have to use a combination of both education and software tools.
Well, we're past the top of the hour. Thank you so much for your presentation and amazing quick responses to all these questions. We did a rapid fire round. You were amazing. So thanks again. And thank you all for being here this afternoon. Thanks for your questions and your attendance. Have a good afternoon.
Thank you. That
Bye,
was good.
everyone.
Bye-bye.